Good afternoon, dear professors and colleagues. I'm Radwa Waleed. Resident of radiology, and today I would like to take you on a short journey from a simple clinical question we face every day to an innovative imaging solution. This work represents a collaboration from the Pelvic Floor Imaging Unit and Research Lab at Cairo University, focusing on how shear wave elastography can change the way we understand ODS. Before diving in, this is our roadmap. First, why did we feel something was missing? Second, how did we try to answer that gap using shear wave elastography? And finally, where this can technology take us in the future? Every meaningful research project starts with a question, not a complex one, but a simple, uncomfortable one. Are we truly explaining patients' symptoms, or just we are measuring some numbers? This question was the real driver behind our work. ODS is a common yet underdiagnosed condition. The patient feels urged to defecate, but evacuation is difficult or incomplete. It affects the quality of life, causes embarrassment, and yet many patients go undiagnosed or misclassified. This makes accurate evaluation extremely important. MR defecography is considered the gold standard imaging modality in evaluation of such patients, but even with all this information, there are some missing questions we cannot answer yet. Previous literature suggested that a narrow anal canal during defecation indicates ODS. However, in real clinical practice, we often see asymptomatic individuals with similar measurements. This mismatch between literature and reality was the spark. It made us pause and question what we were missing. Now here is the dilemma. Here we have two patients. Both show an anal canal diameter below the accepted cutoff. But the real question is, are they truly the same? Should they receive the same treatment, even something as specific as Botox injection, for example? Is anal canal diameter enough to guide the management, or do we need a deeper look at muscle behavior, stiffness, or biomechanics? This is where shear wave elastography enters our story, to show us what MRI alone cannot. Shear wave elastography allows us to move beyond shape and size and start measuring tissue stiffness, a direct reflection of muscle behavior. For the first time, the physics gives us access to physiology. In simple terms, shear wave elastography sends focused pulses into tissues and measures how fast shear wave travel. The stiffer the tissue, the faster the wave. What we get is a quantitative, reproducible measurement of muscle stiffness, something MR alone cannot provide. The key unit here is the shear modulus, which tells us how much force is needed to deform the tissue. So the higher the value toward the red color, the stiffer the muscle. Now let us apply shear wave elastography on the anal sphincter. On this diagram, we see the anal sphincter as it appears on transperineal ultrasound. The inner dark ring represents the internal anal sphincter, and the outer ring represents the external anal sphincter. If we zoom on the external anal sphincter, we find that it is a striated muscle composed of muscle fibers arranged in a parallel orientation, embedded within a background of collagen fibers. Each muscle fiber itself is built from two key protein filaments, actin and myosin filament. At rest, there is controlled overlap between actin and myosin, which generates the resting muscle tone responsible for continence. During defecation, inhibitory neurotransmitters are released, causing these cross bridges to detach. The fibers elongate, the muscle relax, and the anal canal opens. However, when the muscle composition changes, whether through hypertrophy or fibrosis, this normal relaxation becomes impaired. The muscle becomes stiffer, and this altered biomechanics is exactly what shear wave elastography is able to detect and quantify. On beam mode ultrasound, we already see this visually. Here on the left, you can see a transperineal ultrasound image of the anal sphincter at rest. This inner hypoechoic ring is the internal anal sphincter made of smooth muscle, and just outside it, the more heterogeneous outer ring, which represents the external anal sphincter. On the right, we have the same patient during straining. You can appreciate how external sphincter thins out and elongates, and the anal mucosa stretches slightly as the muscle relaxes. Shear wave elastography adds a new layer. It tells us whether this visual change is mechanically effective or not. This slide summarizes how shear wave elastography reflects muscle behavior. Normal contraction of healthy sphincter causes transient stiffness change. Hypertrophy increases stiffness, but the elasticity is still preserved, so the changes are reversible. While in fibrosis, stiffness remains high even at rest, reflecting irreversible tissue change. Finally, the technique matters. In shear wave elastography, accurate results depend on correct probe positioning and standardized acquisition. We use transperineal ultrasound approach using linear high-frequency probe with patient lying in the lithotomy position. In this image, the upper panel shows the color-coded elastography map, giving an immediate visual impression of tissue stiffness, while in the lower panel presents the mean shear wave elastography value measured within the selected region. This standardized technique is what makes shear wave elastography a reliable, reproducible, and clinically meaningful tool. Now, looking to the future, shear wave elastography opens exciting possibilities. It has the potential to become a dynamic follow-up tool, allowing us to objectively track pelvic floor muscle behavior over time. One particularly promising application is monitoring patients after Botox injection, where changes in sphincter stiffness can be directly measured. This opens the door to personalized treatment assessment guided by measurable biomechanics rather than symptoms alone. Finally, I'm proud to say that this work was made possible through the pelvic floor unit and research lab at Cairo University, where advanced imaging meets clinical practice. Our study included 35 participants evaluated using a combined MR difficography and shear wave elastography approach. Importantly, this study didn't emerge in isolation. It was inspired by earlier work using shear wave elastography in the urinary bladder, particularly in patients with neurogenic bladder, where shear wave elastography successfully captured functional tissue changes. Building on that concept, we extended the idea to the anal sphincter and pelvic floor. To continue this journey, my colleague, Dr. Menna Zaki, will now present the original bladder shear wave elastography work, the spark behind our study.
Now I'm going to talk about the first study done in our unit using shear wave elastography on patients who have neurogenic bladder. At first, let's start to say about the standard method used in diagnosis of neurogenic bladder and why we were searching for a new method. Urodynamics are considered the gold standard for diagnosis of neurogenic bladder. However, they are considered invasive as catheterization is needed. This is the image of machine used in urodynamic studies. A catheter is placed in the bladder, then filled with sterile saline. Another catheter is placed in the rectum, and measurements are taken. And here comes a new horizon of the shear wave elastography. Bladder hypocompliance is thought to be due to increase in fibrosis of the bladder wall. Thus, shear wave elastography could potentially be helpful in evaluation of neuropathic bladder by assessing elasticity of the bladder wall. Let's apply together. At first, by the beam mode, we identify the bladder wall. This is the bladder wall, this subcutaneous tissue. We measure the thickness of the bladder wall, which is thicker in neurogenic bladder patient in image A, measuring 4.4 millimeter, compared to the measured in image B of control, measuring 3.3 millimeter. Then we apply the shear wave elastography box. We put the Radwa on the fold thickness of the bladder. We take 3 measurements, then we calculate the shear wave speed mean of the anterior bladder wall. In image F neurogenic bladder, it measures 2 meters per second, which is higher than that measured in image B of control, measuring 1.37 meters per second. These findings were obtained from a case control study conducted in our unit using 20 cases having neurogenic bladder versus control group of 20 healthy individuals to assess the efficiency of shear wave elastography. Sensitivity analysis showed that shear wave elastography of anterior bladder wall can significantly predict bladder wall hypocompliance with p-value less than 0.001 using cutoff point 1.67 meters per second with sensitivity, specificity, and predictive value 100% each. The take-home message that shear wave elastography is a new horizon for assessment of different pathologies on different organs, not only on anal sphincter and bladder wall, for further upcoming research. Thank you.
طيب ميرسي جدا منى.